Welcome to podcast 16, part 2.
I'm Fran.
And I'm Minnie.
And please do feedback to us on this podcast, particularly because it's quite a theoretical podcast. So it'd be nice to know if you find this helpful.
Okay, so the topic is Neonatal Jaundice, part 2. And our tip today is when you have a baby with neonatal jaundice, that you measure and plot the levels on a normogram according to the baby's gestation and age in hours or days since the baby's birth.
Brilliant. So in part 1, we covered the physiology and the risk factors for neonatal jaundice. And in part 2, we're going to talk about the differences between physiological, so that's normal, and pathological, abnormal jaundice. And then we're going to talk as well about the different diagnoses for unconjugated and conjugated jaundice.
Absolutely, Fran. So as you mentioned, we can break it up nicely, the differential diagnosis, into conjugated and unconjugated hyperbilirubinemia. And conjugated hyperbilirubinemia is always pathological. So it's worth remembering that. However, unconjugated, again, can be divided into physiological and pathological. So we'll start with talking about the physiological unconjugated jaundice that we see in babies.
Brilliant. So again, we mentioned this in the last podcast, and it's due partly because of increased red blood cell breakdown and partly the immaturity of the liver of the newborn. It presents on day 2 to 3 and tends to have disappeared by a week, 10 days, completely resolved by 10 days. And the most important thing is that these babies are well, okay? So it can be made worse by bruising. So if there is trauma and bruising from a instrumental delivery, such as forceps or Von-2s, and then it can reach a higher peak because of that, and it may well last longer in preterm infants.
Indeed. Right, so we can break down physiological jaundice yet again into more subtypes, and these are breastfeeding jaundice and breast milk jaundice. So if I first of all discuss breastfeeding jaundice, this is very common, the more common of the two. Now we see this, and it's usually due to an exaggeration of the physiological jaundice that you see caused by dehydration. And this dehydration is caused usually by a lack of milk production or a lack of intake by the infant. We see it commonly in mothers whose milk supply is either small or late in coming in, or there have been initial problems with breastfeeding, getting the baby to latch on. Treatment is by rehydration, and so you continue with the breastfeeding and support mothers as much as possible, but there may be a need for some supplementation with formula, so giving the baby some formula feed as well.
Brilliant. So I don't know if you know the answer to this, Minnie, but I wonder if this is less common in African countries because breastfeeding is far more common, and mothers have done it and they support and things like that, whereas in the UK breastfeeding is actually becoming, unfortunately, rarer and rarer. That I think we witness it less because we have less younger siblings, because our families are smaller. We all live further away from our families, so we don't have that sort of network of parents around us. And unfortunately, in the NHS, there just isn't time for people to help you. So I was saying to Minnie earlier, with my first child, I was discharged from hospital 5 hours after giving birth, and my daughter hadn't fed at all, and of course got jaundice. But luckily, because I'm a doctor, I'm like, this is not right. Sent my husband out, got some formula, and hopefully prevented her being admitted. But I just wonder if there's a difference between different countries as to how often this occurs. I don't know.
I'm sure there is, but I haven't read anything about that actually. But I'm sure you're right. Yeah.
So you out there in Zambia, if this is it'd be lovely to have some feedback. So if you think this is something that you are seeing, tell us, because that would be incredibly interesting for us.
Yes.
Right. Sorry, I interrupted.
No, that's great. So the other subtype is breast milk jaundice, which is much less common, and this manifests, so you see this as a persistent unconjugated jaundice. It starts later, so about day 7, and then extends for 2 to 3 weeks after birth. So it's a sort of prolonged jaundice.
Okay.
It's caused by substances in the breast milk which inhibit the conjugation activity of a key enzyme in the liver, which I'm not sure which one it is, but just so it causes prolonged jaundice. But the treatment is simply to continue breastfeeding and to treat the jaundice if the levels are high enough to require phototherapy, which is the treatment which we'll come on to in the next section, or in the next podcast.
Brilliant. So, so moving on to the pathological, so that's the abnormal unconjugated jaundice. So this is caused by two major mechanisms. Mm-hmm. So one is the increased production of bilirubin, and the second is the decreased clearance of bilirubin. So I'm going to talk briefly about the increased production. So increased production is caused by hemolysis, so increased breakdown of red blood cells. So typically this is hemolytic anemia, so that's hemolytic disease of the newborn due to rhesus incompatibility or ABO incompatibility. So this is when the mother and the fetus don't have the same blood type, and the mother creates antibodies which then destroys the newborn's red blood cells. And you can do a simple blood test of the mother and child. This is something they would be doing in hospital, I hasten to add. And it's called a direct agglutinin test, or a Coombs test. Right.
Okay. So other causes of hemolytic disease, Fran, are inherited red blood cell defects. So this can affect any part of the red blood cell. So it can be membrane, for example, spherocytosis. If there's a problem with the enzyme, such as G6PD or pyruvate kinase deficiency, or a problem with the hemoglobin, such as thalassemia.
Brilliant.
Okay.
And so investigating for those, you do a full blood count, and you do a blood film, a blood smear, and that will help you identify membrane or hemoglobin defects. And then also some metabolic testing if you think there's an enzyme deficiency. Again, we're not expecting you to be doing metabolic testing in your clinics. That's something that a hospital would be needing to do.
Absolutely. So sepsis is another cause of increased production of bilirubin, but it can also present with a conjugated hyperbilirubinemia. So it's a bit of a complicated picture. But a baby that is septic will present to you looking sick, unwell, likely to have a fever, poor feeding, and these babies obviously need admitting to hospital and for the appropriate investigations to be done and antibiotics started. If you're interested, we might do a podcast on neonatal sepsis. Do let us know.
Brilliant. Yeah, so I think that would be really helpful. And then finally, increased red blood cell breakdown might be due to a hematoma. So we've talked about cephalohematomas from von Thuses again. And Minnie, you were saying it's really worthwhile noting, so I didn't know this, it's really worthwhile noting that this hematoma should not go over the suture lines. And if it does, that's a subgaleal, is it? Subgaleal. Now, I have seen one of these. I just can't pronounce it. Hematoma, and that can be an emergency because it can lead to significant blood loss. Yeah. But if you think the jaundice is due to a cephalohematoma, then it's just supportive because the hematoma will normally resolve, as will the jaundice. But again, you need to be measuring the levels, plotting them, because the baby may need phototherapy and fluid resuscitation. And obviously, if there's a lot of blood loss, they may even need a blood transfusion. But I'm not sure I've ever seen that. I don't know if you have.
Very uncommon.
Very uncommon.
Just in very rare instances. The second cause of pathological unconjugated hyperbilirubinemia was caused by a decrease in clearance of the bilirubin. And now this is usually caused by a metabolic defect or an endocrine disorder. So examples of a metabolic defect are things like Crigler-Najjar syndrome, which is really, really rare, and something which is much more common called Gilbert's syndrome. This affects between 4 to 16% of the population around the world. And Gilbert's is a very benign syndrome where people become jaundiced, if they have a mild viral infection and other causes, but it doesn't usually cause any real problems.
Yeah, exactly.
Yeah. And the endocrine causes are things like maternal diabetes or congenital hypothyroidism. Now, certainly in the UK, we do heel pricks on babies to pick up a lot of metabolic problems, and it's a screening program that we do. But babies with congenital hypothyroidism can present before these results are available, so it's worth thinking about. I don't know if you have a similar screening program in Zambia. Again, we'd love to know what you have available to you. But babies that are presenting to you, they just need managing in the appropriate way and treating the jaundice with the ultraviolet light if necessary. Babies of mums with diabetes need their sugars monitoring, and babies with congenital hypothyroidism are likely to need thyroid hormone treatment, but this needs, managing in a centre who are used to managing babies with this sort of problem.
Brilliant. Okay, so that's all the unconjugated stuff. So it's a lot of theory. We're not expecting you to remember it, but it's there so that if you do see a baby with jaundice, you can come back to the podcast, come back to the transcript, and work your way through and have a think about what the baby might have. So I'm hoping it will be useful from that point of view. Yeah. So moving on to conjugated hyperbilirubinemia. So it is always pathological. So it's also called neonatal cholestasis, and it results from extrahepatic, so that's outside of the liver, obstruction, or intrahepatic disease. Yeah. So Minnie, go for it. Tell us about obstruction.
So if we first we'll start with the obstruction. Now, biliary atresia is the one thing that you're wanting to think about and needs differentiating from the other causes. This accounts for 25% of babies with neonatal cholestasis. So it's important to pick up. The other reason it's important to pick up is that it is really important that surgery, because treatment is surgical, is performed as soon as possible to increase the likelihood of success. The longer it's left, the success diminishes, and it's not good news for the baby.
So you were saying before 60 days of age, is that right, Minnie? That's what right. You're aiming for?
That's what the aim is, that the baby has the surgery before 60 days of age. That's right.
But this can be tricky because from what you've said is that the babies are healthy at birth, but then become progressively jaundiced within the first 2 months of life. So you need to be really aware of this, guys, so that that we can. Well, I mean, I don't know if surgery is available in Zambia for this, but it's not that you've got 60 days with which to diagnose it, because the babies, are taking time, to develop it.
Classically, they also have pale or white stools, and this is called acolic stools, and dark urine and hepatosplenomegaly, so large liver and spleen. So these are things to think about when you're examining a baby with jaundice. When you do investigations, they have raised liver function tests, so that aminotransferases are raised and the gamma GT is really high. They do need more investigations in a specialist centre, ultrasound, liver biopsy, usually to rule out other causes. And the definitive diagnosis, Fran, is usually performed in theatre, where they do a cholangiogram to look at the bile ducts. And if they see a biliary atresia, then a procedure called the Kasai procedure, which is a hepatoportoenterostomy, that can be performed. Okay.
But still, even after performing that, you mentioned that 60 to 80% will then require liver transplant later on in life.
That's right. So this is really alleviating the initial obstruction and giving the baby time to grow, with a hope that they won't need further intervention. But yes, as you say, 60 to 80% require a liver transplant.
Gosh, that's quite huge, isn't it?
It is.
Yeah. So other causes of obstructions are rare and the management is variable, but they're things such as biliary cysts, neonatal sclerosing cholangitis, tumours, gallstones, and something called plug syndrome. But we're not going to talk about those in any detail.
Not in any detail. So that's talking about extrahepatic obstruction. Now we need to talk about things going on within the liver, so intrahepatic causes. It's really just a list. So congenital infections, which we've mentioned, we keep mentioning, so torch, that's toxoplasmosis, other rubella, cytomegalovirus, herpes simplex, HIV. And the other thing to think about are urinary tract infections by E. coli. This can make babies extremely sick. Okay, so number 2 in this list are metabolic or genetic causes. Again, it's a really extensive list, but things like cystic fibrosis, alpha-1 antitrypsin deficiency, galactosemia, and lots of other much rarer metabolic disorders, which they need to be seen and treated in neonatal specialist centres, really. The next is toxins. So various toxins can cause conjugated jaundice. And in the UK, certainly on the neonatal unit, the most common cause is from TPN or total parental nutrition. And this happens in about 50% of babies that are on TPN and develops after about day 14. Or there are certain other drugs that a neonate may be on that can cause it too.
Okay, brilliant.
But these are usually babies that are premature and in a neonatal unit anyway.
So it's maybe a bit more obvious then.
Yeah.
So just to summarise, because it is quite confusing, so the majority of infants with an unconjugated hyperbilirubinemia do not have a serious underlying medical condition, and their physiological jaundice will resolve spontaneously with some support.
Yeah.
Such as breastfeeding support, which we talked about. Yeah.
Okay, the pathological unconjugated hyperbilirubinemia has many causes, but can be divided into 2 main categories of increased production of bilirubin and decreased clearance. Now, treatment is important to prevent kernicterus, which we talked about in much detail in the previous podcast, as the unconjugated bilirubin is the bilirubin that can cross the blood-brain barrier.
Right. And then finally, the conjugated hyperbilirubinemia is always pathological, and biliary atresia needs to be excluded as early as possible because early surgery results in a better outcome.
Fantastic. So that brings us to the close of this podcast. And in part 3, we will discuss management of a baby who presents you with jaundice.
Brilliant. Thank you very much for listening.
And goodbye.
Bye-bye.